All right. Well, welcome everyone who's joined us today for this program as part of our CLL 360 series. Today's topic is navigating side effects with the experts, and that's both on the patient side as well as the doctors and the nurses on the medical side. The goal is that you can walk away with a better understanding of what side effects are commonly driven by CLL treatments and how to help manage them, including how to have conversations with your medical team about them. This program is hosted by The Patient's Story. Our multi platform organization aims to help people navigate life before, at, and after diagnosis in human terms through in depth patient stories and educational discussions like this one, which we understand is especially important for a community like this one in CLL, where you're all so engaged and wanting to empower yourselves continuously. This, by the way, was born out of my own experience as a blood cancer patient in non-Hodgkin lymphoma. I remember feeling very alone and also felt that access to humanized information was hard to reach, to get. And so the point is that hopefully this is something that will help fill that void for some of you out there in CLL and SLL. We want to thank the Leukemia and Lymphoma Society for its partnership in this. The LLS offers incredible free resources like their information resource specialists, where you can get one-to-one free support, hopping on the phone or in other ways with their specialists in different areas for blood cancer. And also to the CLL support group on Facebook, led by our friends, including today's moderator, Jeff Fulliter. It is virtual support anytime for folks dealing with a CLL diagnosis. Now, before our speakers, we want to thank our sponsor, Pharmacyclics, for its support, which helps us to host more of these kinds of programs and content, and for free, always to our audience. I do want to note that the patient story retains full editorial control over all of the content, as always. And while we hope that this will be very helpful, that you walk away with better understanding on this topic, this is not meant to be substitute for your own medical advice. Lastly, we really want to hear from you. We know that there's a lot of different things that you all want to know more about and discuss. So please let us know what those topics are, along with what we've done well, and more importantly, what we could do better. So that survey will pop up after this program ends. Okay, housekeeping is over, I promise. And now we get to the great discussion ahead. And now I'll send it over to Jeff.
Thank you, Stephanie. As always, I'm Jeff Folliter. I am a passionate patient care advocate. Why am I an advocate? Because I know that it is truly possible to live a great life, even with a CLL diagnosis. I went through a clinical trial many years ago. I experienced side effects. The side effects in my book were quite profound, but I know so much has changed. There are still side effects, but we take care of them differently. So we have two fantastic medical experts to join us today. Dr. Matthew Davids, Associate Professor of Medicine at Harvard Medical School, Division of Lymphoma. He's a hematologist oncologist at the Dana-Farber Cancer Institute, where he serves as Director of Clinical Research and Associate Director of the CLL Center. That was a whole lot to say. Dr. Davids, I got to ask a question. Why CLL?
So I was very fortunate to be growing up, so to speak, in the era when we were starting to transition away from chemotherapy to targeted therapies. And that really inspired me that we could begin to develop drugs that had fewer side effects and were actually more effective than chemotherapy. And I was really inspired by that and the relationships with my patients. And I haven't looked back.
That's fantastic. Also joining us is Dr. Carrie Rogers. She's the assistant professor in the Department of Hematology at The Ohio State College of Medicine. And I remember to say the Ohio State. Dr. Rogers is a hematologist oncologist and a researcher at The Ohio State University. Dr. Rogers, the same question, CLL, it's not the most glamorous cancer out there. Why did you choose it?
Oh, I wouldn't say it's not the most glamorous cancer out there, although I'm not sure there's many cancers I would call glamorous. Similar to Dr. David, I think he might have been working in the field maybe a few years more than I have. But when I was doing my fellowship in hematology and medical oncology, I had the privilege of taking care of patients on some of the original clinical trials with ibrutinib and got to meet people who had been living with CLL for many times over a decade or two that had experienced a lot of chemoimmunotherapy treatment that were then given ibrutinib in a research study and said, boy, this was the best thing that I'd ever had for this in terms of how it impacted their daily life. And so I thought that was really intriguing. Of course, these drugs we now know are not only generally more tolerable, but also more effective than chemoimmunotherapy. And also just for CLL, I like kind of the long-term relationships you can have with patients, but also the fact that you see people having a variety of experiences with CLL. So you have some people who were quite ill, who have experienced a lot of treatment and may have had CLL that's become resistant to some of those treatments and are, really needing to do a lot of things to manage the CLL. But you also see people who are living with it that are not currently having symptoms or not currently needing treatment. And so I also like the fact that there's some people where you're encouraging them to just do what they want with their life and to not focus on having a cancer. And mostly I'd like all my patients to be bothered by CLL as little as possible in their life, but you do get people in like a variety of situations. And I kind of appreciated that about working in CLL particularly.
Outstanding. Earlier, I mentioned that I've been through one treatment program. I participated in a clinical trial where I received intravenous monoclonal antibodies. Like everyone who participates in a clinical trial, I received a stack of informed consent papers that looked to be about 1.5 feet thick, and it described every single solitary side effect that might happen with the administration of that drug. I was told to expect the first time that I showed up to get this infusion that it was going to take 4 to 6 hours. That, in fact, was a lie. It took 23 and a half hours because I experienced pretty much every single one of those side effects that the informed consent listed. We got through them all. The side effects happened, they were treated. We hit the reset button, we started over again, and as I progressed through the clinical trial, the side effects minimized. That was cool. But now we're in a different world. For most of us, patients, the treatment side effects, they're common, and they can be a little impactful on life. Some of them are temporary, some of them go away. Some of them are more severe, sometimes treatment or even hospitalization is required. And then some people, for whatever reason, never have a single side effect. Everyone reacts completely differently to the treatments. Dr. Davids, the treatment landscape for CLL patients has truly evolved in the past couple of years. Could you discuss how these advancements have impacted the toxicity profile for patients? In other words, how have the side effects of CLL therapy, more specifically the BTK inhibitors, changed over time? And recognize that tomorrow I will be doing my 6-month follow-up at a medical research facility, and BTK inhibitors may be in my future. So talk to the patients, but talk to me as well. I want to know what's going on.
So I'll give you kind of a brief overview to start, and then you can let me know where you want us to dive in deeper. But I would say, just to sort of contrast with the older chemotherapy-based approaches, when I first started, and that's what we were using, I was telling patients, okay, we're going to be starting treatment. You're going to need to take probably 6 to 12 months off from work, go on disability. Your whole life is going to change over this time frame, but eventually you'll get better and get back to what you're doing. So when the BTK inhibitors like ibrutinib first entered into trials, we quickly realized that these drugs are much better tolerated than the older chemotherapy-based regimens. And now the conversation is usually, as you're suggesting, there may be some side effects that arise, but we'll deal with them. We'll support you through it. We'll use various supportive care measures. We may need to reduce the dose and these sorts of things, but you should be able to keep doing the things you want to be doing. You can usually keep working while you're on treatment. The other thing is that we now have a drug, venetoclax, which we give in usually a time-limited fashion, meaning for 1 year or 2 years. And it has a different side effect profile from the BTK inhibitors. But a nice thing about that is when we give a time-limited treatment, when we stop the treatment, usually the side effects go away or are minimized at least. And so there's lots of different options, but that's kind of my 30,000-foot overview, and we can dive in sort of to details if you'd like.
So I want to play back to you what I think I heard. When we first started treating CLL, the treatments were pretty drastic and the side effects were pretty intense for the majority of people. Now, with the new treatments, specifically the BTK inhibitors and drugs like venetoclax, the side effects aren't as intense and are usually easier to treat. Is that a fair statement?
Yeah, I think that's a fair statement. Obviously, there are rare situations where you can have more severe side effects from any drug, but for the most part, most of our patients are doing very well with these new targeted therapies.
It sounds like we're talking about quality of life. And I know for me as a patient, quality of life is at the top of my list. If I can't do the things that I want, we're going to have a conversation and figure out how to get there. So, quality of life is a complex and personal concept, but it is absolutely directly intertwined with cancer treatment side effects. Dr. Rogers, how do you define quality of life for a CLL patient, and how do the side effects of treatment impact this in your experience?
I think that's an excellent question. And I like what you said about quality of life being defined by the person whose life it is, right? So, usually, if we're trying to decide, especially between targeted agents where they're both a good option that have different side effects, understanding what matters most to the patient or what's going to have the least impact on their enjoyment of their life is the thing that we like to do. And it can be different for different people. So, with a BTK inhibitor, some of the common side effects are like bleeding and bruising, joint pains are one, and then risk for abnormal heart rhythms like atrial fibrillation, which if you've had someone that's experienced atrial fibrillation before and it was really bothersome to them, I have a few patients where the atrial fibrillation's been much harder for them than the CLL was at any point. They're, going to try to avoid that because, the treatment they needed and symptoms from AFib was really bothersome to them. Meanwhile, for venetoclax, I think quality of life isn't just treatment side effects, but also treatment schedule. And venetoclax, when given as a first treatment, is given for a year with obinutuzumab, which is a monoclonal antibody similar to what you were describing at the beginning. And that requires an 8-week startup. I thought it was very striking what Dr. Davids was saying is we try really hard now to make it clear to patients that we don't want them to be disabled by the treatment they're going through, even temporarily. So I usually describe it as, and people have told me they worry about this. Like when I do treatment, well, my life is over. I'm not going to do anything. And I'm usually like, no, some people do get severe side effects that have to be dealt with. Mostly we want you to be able to live your life and do what you want with it. And that's kind of how I define quality of life as a physician is I want my patients to be living their life and doing the things they enjoy with minimal impact on this. And these days, I think one of the biggest impacts can be scheduling for treatment because I'm like, okay, you still continue to work full time if that's what you're doing, or like golf full time if that's what you're doing. But you do still have to come for some visits, and that's the biggest thing that changes with treatment. And venetoclax and obinutuzumab requires this 8-week startup, which can be intense. So I've had patients that chose not to do that because they're like, I don't want to take time off work to come to infusion visits. I've also had patients taking Zoom meetings during infusion visits, which I'm totally fine with as long as they're still engaged in their medical care. So, and that's a preference. I don't tell anyone they have to work doing this, but I have some people that just what they love is doing their job and they don't want to step away from it. So the original question kind of about quality of life, it's really defined by the person. And for me, I try to minimize the impact of what we're doing for CLL on people's enjoyment of their life, whatever that is. And that includes side effects, scheduling, both those things, like physical side effects and scheduling. And then also something that I think is not talked about a lot is I do try to think about trying to minimize the psychological impact of starting treatment when I see people that are really fearful of this. And then I see people getting treatment who are like, oh, this is great. I still do whatever I want, right? For the most part. And I think, trying to make sure people know that treatment doesn't mean that they won't get to do the things they like, even though, yeah, scheduling is a thing they're going to have to deal with now for the most part.
Dr. Davids, how do you address the quality of life issues with your patients? What does the playbook look like?
Very similar to what Dr. Rogers is describing. Often if they do want to do the venetoclax-based regimen, it is a bit disruptive to their schedule. When patients are not on a clinical trial, I try to have some flexibility so that, if they have an important event, we can kind of delay things by a day or two here or there. I try to roughly keep them on schedule. It can be a little more challenging when patients are on a clinical trial where we need to pretty rigorously adhere to a specific schedule. For some patients, it doesn't make sense to invest those 8 weeks or so in coming in for frequent visits. A lot of our patients are used to being seen every 3 to 6 months, and now we're telling them you have to come in once or twice a week for a couple months. That can be challenging, and it can be challenging logistically. Some of our older patients maybe don't drive anymore, and they need to get rides, or they live far from the center, et cetera. But that's, I think, one of the beauties of the CLL treatment setting right now is that we have other options. So patients like that can go on BTK inhibitors. They require pretty minimal monitoring, and for some patients, that's really nice for their quality of life. They just come in a couple times early on to make sure everything's going well, and then they can get back to their 3 to 6 month interval schedule. And so I think different options for different patients is a great thing right now. And we're sort of on the precipice of having a new regimen likely approved in the U.S., which is a combination of acalabrutinib, one of the BTK inhibitors, with venetoclax. And I think that's going to be a nice advance because it'll offer the opportunity for an all-oral time-limited regimen. Right now, if you want all-oral therapy, you have to go with the BTK inhibitors and take them long-term for many years. Or you can go with the infusions of obinutuzumab and venetoclax and have that opportunity for the 1-year time-limited therapy. So if approved, which we think it likely will be, acalabrutinib with venetoclax together will be 2 pills. And it's a time-limited treatment of about 14 months or so, and then you're done, and you don't need to go through those obinutuzumab infusions. And so that's going to be nice, hopefully, to have that option for patients as well.
Let's be candid with the folks who are listening to this presentation. Whether you're being treated for CLL, whether you're waiting for treatment for CLL, or whether you're relapsed or in remission, all CLL patients are dealing with some kind of side effect. It's a fact of life. Whether we call it the fatigue, whether we call it low platelets, it makes people bleed easy, whether they have joint pain, whether they have the AFib that you talked about, Dr. Rogers. There's going to be some side effects that people have to deal with. Dr. Davids, what kind of practical advice do you give patients for dealing with those side effects?
So, as you mentioned, the disease itself can cause a lot of symptoms. And in that sense, I wouldn't call those side effects necessarily, because side effects to me refer to something being caused by a drug, but I would just call those sort of symptoms from the disease. And it's actually an interesting study that was recently published where they took patients with CLL who actually didn't necessarily need treatment, and they randomized them to an early intervention approach with ibrutinib versus a placebo. So it's kind of a rare opportunity in CLL to see what happens sort of in a population being treated with placebo. And in that study, there was a 90% rate of side effects in the patients on ibrutinib, and there was a 90% rate of side effects in the patients on placebo. It was the same in both arms. And I think that speaks to how the disease itself can really cause a lot of issues, like you mentioned, fatigue and all sorts of other things. You can see unintentional weight loss, sweats, joint aches, these sorts of things. So, I counsel my patients that, as they kind of stay on therapy longer and the CLL gets into a better remission, I think overall they tend to start to feel better. They'll develop better energy. Their appetite may come back. They may gain some weight back if they've lost weight, these sorts of things. Sweats can go away. And so, I think one of the more challenging periods is kind of getting started on treatment, because that's where you have some side effects from the drugs, and there's still a lot of CLL around, so they may not be feeling great from that. But as they get a few months into treatment, the CLL starts to get better. And so a lot of it's sort of counseling, coaching them through that. Hold out, be optimistic. It's going to get better with time. And for most patients, they may start feeling better pretty quickly, even within a few weeks of starting on therapy, because of that CLL disease control. So that's part of how I approach it. I would say it's also not just me as the physician, but we have a very good multidisciplinary team. We have a great nurse practitioner who's seeing the patients often more frequently than I am. We have pharmacists who also help and call and look for issues with the drugs and side effects. Obviously, the support givers, the caregivers for the patient are a key part of this as well. And so it's a team effort, but I think we do a pretty good job usually of getting patients through that more difficult period and to a better place where they're feeling better.
Dr. Rogers, I want to ask you the same question, but I also want to spike the lead, as it were. It's hard for a doctor and the care team to know how to guide a patient through their side effects. They don't know they exist. How do we do this? I mean, what does a patient have to do to get the best possible side effect care from you and your team?
Yeah, I mean, that's a good question. I think one thing Dr. David said that's important is I'm not the only person. So, actually, different members of the team asking about side effects, nurses, nurse practitioners, or physician assistants, like they help too. Because actually, the nurse practitioner I primarily work with is a man. And so I'll see patients tell him things. Sometimes they won't tell me, or vice versa. So, actually, sometimes the gender of the care provider or the care team member can make a difference in people disclosing side effects. And I think specifically soliciting for them helps. So, like asking about specific side effects that we know are common can really help, because I find people disclose more of them. Like if there's one that's really, I think, ruining what they perceive as ruining their quality of life, or even joint pain, like some people, and this is important too for side effects, we do ask about them so we can get like the spectrum of them. So us asking about common ones, I think, does help people share them more. But sometimes there's side effects that are bothersome to one person that aren't to somebody else, or something like joint pain. We ask about it, we learn about it, we have some suggestions for it in terms of either pain medication, or actually one of the actually, it's our APP team had some suggestions, and I can't remember what the name of this is, but there's like a electrolyte supplement thing that a lot of people seem to be finding very helpful. It's like, I think, magnesium, calcium, something that they've been suggesting for patients. But sometimes we suggest that, and then when the patient comes back, they're like, "Yeah, I still have the joint pain." We're like, "Did we try this thing?" And they're like, "No, I didn't." I'm like, "Oh, why not?" And they're like, "Well, I don't care. The joint pain was fine, and I don't want to try something for it." So I think too, like even though we suggest management of side effects, if the person's happier living with it than trying any sort of intervention, I'm okay with that. So we do try to solicit for it, but you do also have to kind of like say like, okay, is this something, or, I suggested all the time for side effects to do this or that or the other. And they're like, you know what? I'm actually really happy with it. I don't want to go out and try anything. And then you're like, okay, but I feel like I've done my job better if at least I found out about it and suggested something that they were like open to trying if they were bothered enough. So I think that's part of it too.
That sounds great. Dr. Davids, it's sounding to me that in the current landscape, many, if not most, of the side effects are fairly easily managed for CLL patients, whether it's something like a couple of Tylenol, this electrolyte drink. Let's talk a little bit about how you do deal with these side effects. Is it mostly, hey, take a couple of Tylenol, the joint pain should resolve? Is it a matter of you might want to look into some diet modifications? What's going on with these side effects? What are you doing?
So every drug is different, every side effect is different, every patient is different. So I can give you maybe a couple of examples. I'm sure Dr. Rogers can as well. Sometimes we do see more significant side effects with, for example, BTK inhibitors, where we run into issues with bleeding, and that rarely can be more serious. And so one thing that's very important for patients on BTK inhibitors is to know that if they need any kind of surgical procedures, they need to stop taking their BTK inhibitor before and after the procedure. And I think it's usually helpful for patients to kind of check in with us, because every procedure is different and may require a different length of hold. So I have seen some patients run into issues where they forgot to call and ask us. They were taking their BTK inhibitor and they had pretty serious bleeding issues after a surgery, for example. So that's one example that comes to mind. And that's really about communication and also anticipation. I myself may not be thinking about a procedure I need until a couple of days before. And it turns out I needed to stop my BTK inhibitor 7 days before. And we've had situations where we've actually had to postpone surgeries because of that. So just being very proactive and communicating with your doctor, I think, is really important about what's going on for that particular one. For other things, another common one that I see with both venetoclax and with the BTK inhibitors is diarrhea or loose stools. This is particularly when patients are first getting started on these drugs. I think there's a period of time where your body kind of needs to adapt to the drug. And so, if it's pretty significant diarrhea, we usually want to do some testing first before we do interventions. So we'll look for certain infections, for example, something called C. diff, which can be a more serious infection. It's usually not there, but we like to make sure that's not there before we recommend things like Imodium, which kind of slows down the bowels. And so usually with kind of using Imodium, and sometimes actually taking the pill at a different time of day can be helpful, or with a different type of food. So sometimes venetoclax, I've had luck with patients taking it with a fatty meal sort of at night, and then when they wake up, they feel better, and they're not having diarrhea during the day. So there's little tricks like that as well. Sometimes we need to reduce the dose of the drug, and that can help with diarrhea. But I do find that usually within the first couple months that settles out, and for most patients, you can then kind of get back up to the full dose of the drug and maybe back off on Imodium and things like that. And so that's just a couple of examples of how we handle things.
Dr. Rogers, we just brought up the concept of dose reduction. And I want to get your take on this because, for whatever reason, there's a lot of patients who are actually uncertain and fearful regarding dose reduction because it introduces a cloud of uncertainty to what's going on. Can you speak to that?
Yes, definitely. So I think, and I think this is true actually across other cancers as well. People worry about dose reduction, I think largely because they worry the treatment will stop being effective if the dose is reduced. So venetoclax, for example, the target dose for most people that don't have drug interactions with it is 400 milligrams a day. Um, However, when people have been on it for a while, I think there's certainly efficacy at 300 milligrams a day or even 200 milligrams a day. You do start to worry if you're taking like 100 milligrams twice a week that that's not going to work, right? So I do think there is a point where you get things reduced to a dose where most people think that that's not going to really be effective, or like with BTK inhibitors, you know that the target's not going to BTK is the target of the drug. You're not going to have occupancy or basically the inhibitory action. But there is a lot of room for dose reduction before you get to a point where the drug's not going to work. And there's reasons to think in people with side effects that maybe the dose that's the target dose isn't the right dose for them. In fact, when we do studies to design dosing of drugs, they look at drug levels in the blood, biologic, like outcomes like how much of that BTK protein is occupied with different dosing schedules. But that's in a group of people, and individuals, of course, can have different experiences with it. And there's some thought, and in fact, some data to support this, that people with side effects might actually just naturally have different drug metabolism, and that maybe what's needed for them is a different dose of the drug. And then again, talking about BTK inhibitors, there's some scientific evidence that early in the disease, because it binds BTK permanently, that the drug is actually cleared by the amount of BTK in the body, which is a lot when there's a lot of CLL. Farther in is actually not a lot, and the protein production is downregulated. So it's quite possible that less drug is necessary to maintain that response after the first kind of beginning of treatment. And I do think, especially early in treatment, kind of like Dr. Davids was saying, some of these side effects improve over time. And, people see that they have a lot of CL in the body. They see things improving every time they come for a visit. And then they're like, okay, I'm having X side effects. That's cool. Everything's getting better. I clearly need this. But then when you're looking at like joint pain that's interfering with your pickleball game a year in, when your blood counts look good, maybe that's a time to think about doing a dose reduction for something that wasn't ruining your quality of life early on, but after living with it for so many like months now is. And that's also a time when the CLL is in a different spot and dose reduction might be more reasonable. And, there's even some and I was involved in one of these projects, but studies looking at claims data. So this is a way to do research looking at databases of people using these drugs through insurance claims, showing that actually reducing the dose did not result in a sooner time to being prescribed a new treatment. In fact, it looked like it might even be going better for people, probably because they were able to tolerate and stay on this drug. So I do think it's always worth asking, your physician anything you're worried about. And certainly if a dose reduction is suggested, talking to them about if they expect this will change your treatment outcome. But there's plenty of reasons to think that in most cases it will not. again, when you get to very low doses of drug, or I've seen some really weird treatment schedules out there, like taking a BTK inhibitor every third day or something. At that point, I really think, it's time to pick a new treatment or do something else. But there's a lot of room for dose reduction in a way that we know is not going to compromise how well the treatment works. That was very long, so hopefully I didn't steal points from anybody else. Sorry, I was kind of rambling there.
That was absolutely perfect and actually quite timely because it's something that's on people's minds right now. We've talked about these side effects. We know that they happen. We've talked about the difference between male and female patients and how they communicate these side effects to their care team. I'm going to toss this one up, and whoever grabs it first, go for it. Is there a way that you prefer patients communicate this stuff to you? Is there a playbook that they can use to more effectively communicate with you? I know for me, it's taking my wife to these appointments because everything that I forget to say, she makes sure is said. Good strategy for me, not a great strategy for everyone else. So the question is
Yeah.
served up. Somebody grab it.
I'll start if that's okay. So I think the other strategy I encourage patients to do is to make a list of their issues ahead of time before coming to the visit. Because when you get to a visit, sometimes it's a little deer in the headlights. You have your half an hour or whatever it is, if you're lucky, if it's maybe even less time. And sometimes people just don't think of the things that have been occurring to them. So I just kind of say keep a little notebook. Over the course of the say 3 months in between the visits, just jot stuff down. And I personally find it sort of most efficient to kind of go through all those things in person together with the patient, counsel them through each one. I don't mind if it's a long visit. Like I think that's really efficient. I think a challenging mechanism that has developed over the last, say, 5 years or so is using like a patient gateway to communicate, which I think has pros and cons. I think it is good for patients to be able to access their care team. But I do find sometimes, like over those 3 months, like certain patients kind of think of a question, they send a gateway message. Think of another question, they send another gateway message. So they may be sending 15, 20 messages in between the 3-month visits. And so it's a lot of time on our end to kind of field all those things. And we try to be as responsive as we can. We've hired actually additional staff just to manage the volume of all these messages that come in. Because you can imagine if you have 10 or 15 messages from 200 or 300 of your patients, it's a lot. So there's a role for it. I'm not saying that's a bad thing, but I think we need to kind of rethink a little bit how we do that. And certainly, I encourage patients if they're having more acute side effects to actually page us directly. We're available to call back, and we have teams to help support us in that as well. And if you're sitting on a more serious side effect, that's not a good thing. So communication really is key, but kind of being smart, I think, about how to communicate, what's most efficient both for you and for your provider is going to probably get you the best answers, the most relevant answers that help you.
I see a lot of head nodding, Dr. Rogers. I know you want to jump in on this.
Yeah, I mean, I think definitely like deciding ahead if there's things you want to discuss, and then like making a list that either you keep or your spouse keeps. Or I've actually had a couple people that like the week before their appointment send like a list of questions ahead through the patient gateway or portal that they're like, cool, we're going to talk about this Monday, hopefully. And then I'm like, okay, we have a list now so that they know what it is. I can read what it is. And then, it's whatever helps them. Like some people make paper notes, some people have it on their phone, like whatever they need. But I definitely think if it's something that really matters that they want to discuss, deciding ahead what that is, and then using your visit time to do it. I think like the patient gateway or portal is an excellent communication tool. But I agree you can't be doing that like every day, just asking something new. I think like one thing to do that sometimes works is people will, and also we do those business hours. I tell my patients, you're welcome to write us a note at 2 a.m. We will not be replying until the next business day. So like, but if you're up at 2 a.m. and want to send us a note, that's cool. As long as we're not going to read it until business hours, right? But like sometimes too, like you'll get people that send a bunch of concerns. I'm like, okay, I see your list of concerns. We can't answer this on the phone. We're going to schedule you to come in and get this like dealt with. This is really important. Or, occasionally we'll provide education like this is a concern. This is actually something that should be handled by the phone so we can call and get it sorted out. But I think like if there are concerns, if it's an easy question, like I'm getting a tooth extracted, what do I do? That's something I didn't expect. I just need to know, like, that's really helpful to send by that, especially people that like using that I also have some patients who do not use my chart. That's our patient portal tool. And so if they have a different way they communicate with us or calling or whatever. So I think it's good to have multiple approaches for getting this addressed. In terms of making a list of questions though, I think ahead and then, send it ahead, bring it ahead, whatever helps you stay organized so that you get the answers you need. There's something we didn't talk about yet, which I think has actually been very helpful for us, which is open notes. So the government, actually, this is not our decision, this was a government decision, has required that we provide all test results to patients immediately and provide notes from my notes actually are available to the patient. Some people like reading them, some people don't. But I have found that my patients will be like, oh yeah, I went back, I couldn't remember something you said. I went back and looked at what you wrote, and that really helped me out. And then I didn't have to call you because I saw what you said in your note. Some people know how to look at those, some people don't. They're not written in patient friendly language. Those are our notes, so they're provider notes. But I think having that available, and to patients will get their blood test results if they want to look on their phone, sometimes before I've even come to see them, so they can think of questions about their CT scan results if they're done ahead, lab results if they're back before I'm in there. And that helps them think too about what they might want to ask me about that so that I can address that during the visit. Overall, I think it's an overwhelmingly good thing to allow people access to their health information immediately. But I have had a few patients that then called us up very angry that we had released CT scan results on a weekend. We didn't do that. Radiology did that, and then they thought they had no way to reach out to us about something they were terrified about, which is also not true. We have a 24-hour answering service if people are extremely worried about a test result that was released to them by the system on a weekend. So I think understanding that process too and the value in it, but also thinking through as a person, do you want to open your test results on a weekend is really key, and you have to do the thing that's right for you. I don't know if Dr. David has points on that one either.
Yeah, I feel very similarly about the test results. I think it is great to have access to all your data, but you kind of have to know yourself. And if you're the type of person who's going to freak out if you see something strange in a report and it's a Friday evening and no one's going to be able to get back to you for a few days, just don't open the report. I see our job as kind of looking at those reports, kind of filtering out the things that maybe aren't worrisome and telling you what's important. So all the time, patients will be very worried about a tiny little lung nodule that wasn't described before. And if it's 2 millimeters, I'll just say, oh, don't worry about it. It's nothing. But if you see that result first as the patient and I'm not immediately available, you may be worried for days. And so, some people, it doesn't bother them and that's fine. Just look right away. So you just kind of have to know yourself and what you're comfortable with.
Right, and we still have a system where if it's an emergent result that needs someone to go to the ER or emergent action, which almost never happens in my clinic, there's still a system for the radiologist to call me and me to contact the patient. We don't release test results with emergent findings without anyone on the healthcare team being notified about that. Which I think some people don't know. We also had someone call up extremely angry that a completely normal CT that they expressed no worries about when we asked them, this wasn't my patient, it was a colleague's, was very angry that we released it on Saturday afternoon. First of all, we didn't do that. Second of all, they had no concerns about it, and it was actually a very normal report. So I think trying to understand how people feel about that and how to use it is really important.
This is really, really good stuff. I know for the past couple of years, as I've sat in the waiting room after having my blood work done, I have a very distinctive text message alert sound. And sonar sound starts going off from my phone as my test results start coming in. And I know I am one of those people that I'm face down in the phone almost instantly because I want to know what questions to ask my doctor when I go in to review those results. I'm coming up on 15 years of living with CLL, and I've learned that the most important thing is not one test result, it's the trend of the test results and how things are going over time. Not everyone is there yet, and this is part of how we communicate with our care providers. This is how we work with our team as a team member. So we've been talking about these BTK inhibitors, and I feel like I start mumbling when I say ibrutinib and acalabrutinib and zanubrutinib and pirtobrutinib. And it seems like the drugs just keep on coming one after the other after the other. It's an avalanche right now. And I know that when I started, there was no avalanche of drugs. It was pretty much nothing or FCR, and that was it. And now we've been doing all this research. So let's shift gears. Let's talk about how we got to here. We have all these BTK inhibitors. We have venetoclax because we've been doing clinical trials. We have CLL patients participating in clinical trials. We have the data that's coming back. How do you anticipate these advancements in all this stuff is going to impact treatment decisions? Are people going to put off starting treatment because something new is right around the corner? I'll start off with you, Dr. Davids.
Well, the first thing I'll say, and you kind of alluded to this, is that we wouldn't have all these great new drugs if patients didn't go on clinical trials. And so the patients who sort of came before in the past few years really helped to bring these drugs to the patients of today. Patients of today also should consider clinical trials because you can help to develop the next wave of drugs for the next wave of patients down the line. So really, patients deserve a ton of credit for making all this possible. Um, I would say, ibrutinib was a huge advance. And when I heard about a new BTK inhibitor coming along, acalabrutinib, I was pretty skeptical at first. I was like, we already have a great drug with ibrutinib. Why do we need a second BTK inhibitor? And it turns out that acalabrutinib is equally effective as ibrutinib, but has a lot fewer side effects. So it was actually a big innovation that acalabrutinib came along. And then zanubrutinib came along, and I said the same thing. Why do we need another more selective BTK inhibitor? It turns out in one study, zanubrutinib is actually better than ibrutinib in terms of how well it controls the CLL, and it's better tolerated. So that seems like an advance as well. And then with pirtobrutinib, a fourth BTK inhibitor, but pirtobrutinib works very differently from those other three BTK inhibitors, and it can actually work even after all three of those other drugs stop working. So that's a big advance. So I've been kind of proven wrong at each step along the way. It's helpful to have 4 different BTK inhibitors. I'm trying not to make the same mistake with a new class of drugs called BTK degraders, which are now in early phase clinical trials. This is another way to target BTK and actually is showing some significant promise. And so it's possible and very likely, I think, that eventually we'll have at least a 5th BTK inhibitor approved in this disease. And it's not what we'd call Me Too drugs, where it's really just the same drug with a different label. These are all different drugs. They all have pros and cons, and there's a role for each of them right now in treatment of CLL. So it's really exciting times and continues to be exciting for patients to have all these options continuing to evolve.
I believe that was known as a tease. What would you like to add, Dr. Rogers?
Yeah, I completely agree. Like the only reason that we have these drugs is because people were willing to participate in clinical trials. I also see people sometimes that are afraid of participating in a clinical trial, or even after I've explained a study that's like a phase 2 study of a drug regimen, still fear they're going to get a placebo, even though that was not part of the discussion. So I think some of the lack of understanding for what research participation is, is a barrier to people doing it. And it does, take a lot of courage to do something where we don't have all the information about how this particular treatment scheme is going to work. For example, a study we have right now for people experiencing a first treatment is a combination of currently approved drugs. So mostly when people hear what it is, they're like, okay, neat. Like, these are drugs that you're just talking about as standard of care. It does take some courage to try like the new combination or scheme for giving them. But I think that really helps with the understanding. And then I always try to remember to cover that people will not be getting a placebo because we actually don't have that in any of our current CLL trials. I think one thing that someone said once is that participating in a clinical trial is like getting tomorrow's treatment today. And so some people that are worried about it or, don't want to take an investigational drug, I like to remind them that these currently approved drugs we have were drugs that people got here at Ohio State. And I know where Med is at Dana-Farber is a similar thing. They got these drugs as research participants way before they were on the market, and these are now currently approved drugs. So they were able to benefit from what is a highly effective therapy before it was commercially available, and people that are treated at sites that don't do research or weren't study participants were able to benefit. So this can actually directly improve the type of treatment people are getting, even though there's some element of unknown because it's a research study. And of course, we're trying to learn more about these drugs. And then I think for anyone considering research participation, definitely asking like, what's known about the drug? Where is it in development? What is the goal of this study? Can kind of help people understand it better. But I do like to point out that when people are excited about approved drugs, that here we were able to treat people with those drugs before they were commercially available because they were participating in research. And I would never suggest a clinical trial that I didn't think was going to be highly beneficial to the person who was going to take that as a treatment. And then, we've talked a lot about a little bit about choices for taking like a first targeted agent, but there are people who have had CLL that's now become resistant, as Dr. Davids was just mentioning, to several of our targeted agents. And that's really a spot where drugs we have investigationally are much more likely to be a good benefit to them or be effective for their CLL than drugs that are currently on the market. And so that is a huge reason for people to consider research participation. At that point, you are going to get something that we know is very likely to be better than commercially available drugs. So I also had a very lovely patient who was on observation and didn't need treatment that was really pumped he could get a drug that's never been given to people before. And I was like, well, I don't think we're doing that right now, but I really like the attitude. So
I love it. I'm going to
yeah.
keep you on the line for just a few more seconds because what you were saying has got me thinking about this process as a collaborative process. It used to be, like it or not, the paradigm was a patient presented with an illness. They saw the doctor did an evaluation, the doctor prescribed a course of treatment, the patient took the treatment, and that was that. Things have kind of changed now. We have a lot of options. There's maybe five BTK inhibitors. There's venetoclax. There's no treatment. There's monoclonal antibodies. I would like to think that we're moving closer to a collaborative environment where the care team does the decision matrix with the patient. Dr. Rogers, how do you foster that environment with the patient?
Oh, I think I try and strive to make my clinic a collaborative environment. And, right when venetoclax and obinutuzumab was approved, you have this like BTK inhibitors versus venetoclax and obinutuzumab. And I had a lot of consults to my clinic for people like considering their options for first treatment that come, sit down, I introduce myself, and they're like, what treatment should I do? And I was like, I have no idea. I don't know anything about you yet, right? So until I get to know you, I can't help you. I can't tell you what to do. And then usually I'm like, tell you what, why don't we talk? I have some questions for you. You probably have some questions for me. We'll discuss the treatments. And I bet by the time we're done talking, it'll be clear what to do and we can decide together. So I think that's the best approach. There are some people, I like collaboration, and there are some people that actually don't want to get options. There's some people that are very overwhelmed by the options, so want a recommendation after a discussion, but there's some people that are, I don't want to think about this. Like, yes, ask me what you need to know to make the best recommendation for me, but I don't want options. I just want you to tell me what I should do. And so if you get that from someone, I actually find that super hard to just pick for someone. And I have to ask them enough questions so that I can kind of make the recommendation for what I think will be best for them. But I do respect the fact that some people, get overwhelmed by the choices, don't want to have options and really just want to be told what to do, because that's not the way I prefer to do things. But if that's what the person who I'm taking care of wants, then I try to do that.
Dr. Davids, your take on the collaborative approach?
Yeah, very, very similar approach. I would say, I think, as Dr. Rogers is saying, there are patients who prefer to be just told what to do. And so I think it's really important to ask what their preference is up front about how they want to approach it. And so that is one scenario. The other scenario is kind of just completely leaving it up to the patient, like just presenting the options as all being equal and letting the patient choose. I tend not to do that so much either. So I try to kind of narrow it down for patients. Often there'll be kind of one or two options that I would prefer for the patient. And, sometimes you get the dreaded question, well, what would you do if this was your sister or your mother? And, I would recommend for a patient anything that I would for a family member. If I'm making a recommendation, it's because I believe in it, no matter who I'm recommending it for. And so, there are scenarios where, we've kind of gotten down to maybe two or three options, and the patient will ask, and I'll say, yeah, I would lean more toward this one based on what you've told me. But these other choices are reasonable too. So think it over. So ultimately, it's the patient's choice. I see my role as kind of guiding them to that choice, and sometimes it does help. I think if I express what my own sort of thought is for a particular patient, a lot of patients do find that helpful.
Excellent. As we wrap up this discussion, um, I come to the one question that I ask to each of you. It's a simple question, but it's also very, very loaded. A brand new CLL patient comes into your clinic, Dr. Rogers. Brand new patient. You meet with them for 14 minutes. The mid-level practitioners have done their thing. You've got 60 seconds to give them one message. What do you tell them?
I usually tell people that we expect them to live with this for a very long time. And so the goal is to help them live as well as possible and be the least bothered as possible by the CLL.
That didn't take 60 seconds. So Dr. Davids, you get 75 seconds if you want.
I don't think I could say it any better than Dr. Rogers did. I mean, it's really a similar message. I think it depends a bit on the age of the patient. For patients now diagnosed with CLL in their 70s and 80s, which is a lot of them, I always say to them, like, our goal here is to have you live whatever your normal life expectancy would be otherwise. You'll probably be living with CLL, but we have very effective treatments, and it's unlikely that this is going to shorten your lifespan. For younger patients, I don't feel as confident saying that yet, because if you're diagnosed with CLL in your 50s, we don't know what happens 30 years from now with these targeted therapies. And so, I tell those patients, we already have a lot of good treatments, but over the next few years, we expect even more good treatments to be developed. And the longer you live with CLL, the longer you're going to live with CLL. Because we'll have more and more treatments available. So I also try to be positive and optimistic, even with the younger patients. And so that's usually my approach.
Thank you very much, doctors. This has been absolutely wonderful. I will be candid and confide in you that I was diagnosed with CLL at age 46, and I am now 60. And currently, I'm knocking out between 40 and 55 miles every week speed walking. I am eating well. I am drinking well. I am being a good father. I'm being a good husband. I'm doing all the things that I would want to do if I didn't have CLL. I'm living a, frankly, damn good life. It's my mission as a patient advocate to make sure that it is possible to live a very good life, even with a CLL diagnosis. I take an active role in my own care. That means I actually listen to my care team when they say you need to do this, this, and this. You need to watch your comorbidities. You need to take care of this. You need to stop eating all those starchy carbs. You need to, the whole laundry list. I'm doing what I need to do to present my body to my care team in the best possible shape so that when it is time to treat, we get to dial that wheel of BTK inhibitors or BTK degraders or monoclonal antibodies or venetoclax. We get to pick the right treatment plan so that I can live my best life. That is literally what I want for every single patient and caregiver who's listening to this program. It's important. You can live a very long, very good life with CLL. So thank you again, doctors, and thank you everyone here for participating and listening to what we have to say. I'm going to hand it over to Stephanie.
All right. Thank you so much, Jeff, for your guidance in the conversation, for your perspective. We always want to make sure that we are emphasizing what that patient and care partner voice is. It is critical, obviously, beyond just the education here. And also, thank you so much to Dr. Rogers and Dr. Davids for not only being incredible as CLL, SLL specialists, but also for providing so much more time and extra time in helping the community beyond the people and the patients you see in the clinic. So thank you. Now, we do want to make sure that along with this topic, more conversation about what's impacting your quality of life, we want to understand more about what is impacting you. And so that survey is incredibly important for us. It's going to pop up after this program ends. Let us know what you think. It's really important to us. We also want to say thanks again to our sponsor, Pharmacyclics, for its support of our independent patient program. And special thanks also to our partners, the LLS, the Leukemia and Lymphoma Society. Check out the links on the side here for the LLS website. There specifically is info about the information resource specialists that are provided, where again, you can get free one-to-one support on so many wide-ranging topics. And also to the CLL support group, which Jeff, our moderator today, helps to lead. That group offers on Facebook an active community of patients and care partners with so many different backgrounds that can offer a lot of support. So thank you so much for joining us today. I really hope that this was helpful in one way or another. Again, we really hope that you filled the survey so we can learn more on what we can do better. For now, we hope to see you on a future program. For The Patient Story, I'm Stephanie Trong. Take good care.